Well, let me formally say good morning to everybody. My name is Lynn Zucker. I'm the Vice President, Clinical Systems Integration from Canada Health Infoway, and you'll see a lot of me over the next couple of days. But it's my pleasure this morning to introduce our next panel. A little editorial for you. Last year, we leaned on the province of Alberta to do a very similar panel as this plenary this morning, and it was the most popular session at the conference last year. So we phoned up the folks at Saskatchewan and asked them to do something very similar, and I'm expecting great things from this group.
No pressure.
And those of you that are from neither Alberta or Saskatchewan, look out, because if we do this again next year, we'll need another province to step up. So you can run if you see us coming. Anyhow, our panelists this morning are going to be introduced by the first speaker. So it's my pleasure to introduce Susan Antosh, the CEO of eHealth Saskatchewan, and we'll get started with no further ado.
Thank you. So I have the pleasure of introducing some folks who've worked a lot with us at eHealth Saskatchewan throughout, in some cases, years, and in some cases, a shorter period of time. And I'm going to just introduce them first, and then I'm going to ask them what made them want to become involved in this area. So directly beside me here, to my right, is Cecil Snyder. And Cecil is a patient advocate. And he's going to tell you a little bit about his story as we go through the next question. Besides Cecil is Barb Beaurivage, and Barb is a nurse practitioner who works with Regina Qu'Appelle Health Region. And she is a part of our peer-to-peer program with the nurse practitioners. Beside Barb is Didi Emokpare. Didi is a physician in private practice. He also works with us as our Chief Medical Information Officer. And so that's, he'll talk a little bit about his experience in both areas. And then finally, on the far right there is Kimberly Sentes. And Kimberly is a pharmacist with Towers Pharmacy, so with one of our for-profit. Anyway, one of our private pharmacies, and she is also part of our peer-to-peer program. So maybe, Cecil, I'm just going to start with you, because then you can get it out of the way. How did you become interested in working on e-health and information flow?
Well, in 2006, my wife, Joyce, was diagnosed with a brain tumor. And over the next 7 years prior to her passing in 2013, she and I got a first-hand view of the healthcare system and the way it operates. And after expressing my frustration with the healthcare system and the treatment that my wife was receiving during those 7 years, a client representative with the Regina Qu'Appelle Health Region asked me if I would be interested in participating in a citizens advisory panel. And I accepted that offer, hoping to prevent other patients and families from enduring some of the things that we went through. My biggest frustration was with the fact that people within the healthcare system seemed either unable or unwilling to communicate basic information with one another in an age known as the information age or the age of computers. So the inefficiency in the system was hard for me to understand because in most industries, that's the norm. The use of paper files and fax machines has disappeared in most industries. Over the span of 7 years, Joyce was in and out of the system many times for surgeries, treatments, in a few cases for emergencies. But not once was she ever admitted to hospital, received the treatment that she needed, and ended up being discharged without an error occurring, which caused her discomfort, pain, and in a few cases actually threatened her well-being. So I'd like to share just a brief story, if I have the time.
Sure.
Which was really our indoctrination into the healthcare system. As I said, in 2006, Joyce was diagnosed with a brain tumor, and she underwent surgery to attempt to remove that tumor. Before the surgery, we had the opportunity to talk to the doctors and nurses about the surgery and inform them that Joyce did not respond well to morphine. So this knowledge was based on a previous surgery where it was discovered that it didn't work for her, and in the end they had to use Demerol for her pain relief. So our comments were ignored, and this resulted in Joyce spending a great deal longer in the recovery room than was expected or normal, in a great deal more pain. As part of the recovery process, after this surgery, she was to have an endoscopy to check her esophagus. And as luck would have it, the day of that procedure, her feeding tube plugged up and it was removed. So in the end, the procedure was not done, and a new feeding tube was not inserted, nor was an intravenous started to provide her with fluids. The following morning, when I returned to the hospital, still no intravenous, still no feeding tube. So when this situation continued into the afternoon, I asked the nurse on duty what the HE double hockey sticks was going on. And as you can imagine, my comments weren't well received. That is until I asked her what she had had to eat or drink in the last 20 hours. So that's when the light bulb went on, and Joyce was taken downstairs for the procedure, and prior to the procedure, an intravenous was started. So the report from the endoscopy recommended that the tube feeds be withheld for a minimum of 24 hours to allow for her esophagus to heal a bit. The next morning, the same nurse was at her bedside asking me to leave so that she could insert a feeding tube. Another discussion ensued, which ended when the nurse actually went back to her station, found the report from the previous afternoon, and read it. So looking back, it became obvious to me that many of these errors occur due to poor communication regarding Joyce's medical history or her current needs. And I think that a lot of that has to do with paper files which seem to get lost or misplaced, not to be used. So it's my belief that an accurate and detailed electronic record for patients that is accessible by patients as well as medical people is needed in order to eliminate some of these errors. I was kind of happy to hear the first two speakers today speak so much about the patient coming first.
Okay. Barb, maybe you could tell us a bit about why you became interested in eHealth.
It's actually started many years ago as a floor nurse at a hospital, and they implemented an admission discharge system and order entry, and they were looking for nurses to help train other nurses on how to use it. So that's sort of how it initially started. When I became a nurse practitioner and joined the family medical unit, it was an academic health sciences primary care clinic. And I think because I was the last person in, right after the EMR got implemented, I was chosen to be the EMR lead for our clinic. So it was no easy task, and my job was to do some training, but also standardize 10 physicians and 16 family medicine residents into charting the exact same way and using the system in the exact same way. And as a result of that, I became involved with eHealth and became a nurse peer, and have had lots of opportunities with eHealth to come to sessions like this, and also to be a part of the 5-year strategic plan that the province of Saskatchewan put together for IMIT support.
Didi?
My eHealth journey started about a year ago. I joined eHealth Saskatchewan as medical advisor and chief medical information officer. My journey really with electronic health records would have been a preceding event, and this was when I did my residency about 17 years ago. I started in a residency program in the US with electronic medical records, and I ended up moving to Saskatchewan to practice. To my surprise, it was all paper charts. It was sort of like going back in history. But the inefficiency for me as a private physician was apparent as compared to the sort of the public or the salaried physicians. So in the private practice world, you do have to drive efficiency. And I think that was probably the trigger for my interest in better electronic records, et cetera.
Right. And Kimberly.
I became involved with eHealth many years ago before it was eHealth Saskatchewan. I was lucky enough to practice in British Columbia after I graduated from university and worked with integrated PharmaNet as soon as I started practicing. And then about 12 years ago, I moved back to my home province, Saskatchewan, and was like, oh my gosh, how can I practice without drug information? How can I actually do my job as a pharmacist without being able to see what patients have had filled and where and when? So I became involved with SHIN and HISC at that point in Saskatchewan and vocalized the urgency, and PIP was already established and rolling out, and I was very excited about that and wanted to volunteer my pharmacy for any pilots and anything that I could assist the government with at the time. At that point, I was appointed to the Saskatchewan Lab Result Repository, and I became involved with the development of the electronic health record in Saskatchewan.
Okay. So that just gives you a little bit more information about how they've been involved. For the sake of this presentation, we do have all of the core components of the electronic health record in play. And about 85% of our physicians are now using an EMR, or our clinicians, actually nurse practitioners as well, and midwives. And we have a variety of information that's available. But we're going to actually focus for the purposes of this presentation on kind of 4 key components that are part of our interoperability journey and how those actually are impacting or affecting our panelists. If there's not time during the presentation, you can certainly catch me afterwards, and I'm more than willing to talk about some of the other things that we're working on. So the 4 areas that we're going to actually focus on are the Pharmacy Information Program, or PIP, what we call PIP in Saskatchewan, Chronic Disease Management and Quality Improvement Program, Electronic Health Record, or the EHR Viewer, and the Citizen Health Information Portal. So within the Pharmacy Information Program, we have all community-based pharmacies that are tied into the Pharmacy Information Program. About 90% of our pharmacies are integrated using CeRx messaging. And we are working on that very last 10% that are supposed to be in by the end of the year, so by March 31st. You can actually, you can view dispense transactions basically in real time, 5 to 9 seconds. You're able to track if it actually was dispensed, if it's on hold, if it's pending. And the information out of here is used for a lot of different purposes, including med reconciliation, obviously, drug utilization review, and a number of other things. So Kimberly, maybe you can talk a bit with us about what difference PIP has made in your pharmacy practice.
Obviously, from my prior experience in BC, I really couldn't imagine practicing without it. And to this day, I just think, how can a pharmacist not access the data, which is still happening in about 10% of our pharmacies that are not integrated. It is an immeasurable tool for us to provide patient care, to provide med reviews, med assessments, care to long-term care residents. I can give an example of a patient who came in on the weekend with their small child. They were getting a prescription for an antibiotic, and I, of course, viewed the integrated PIP profile and seen that this 3-year-old had had antibiotics, I think it was 18 times in the last 25 months, because our data is held in PIP for 25 months. And I just counted it because I just kept seeing the same antibiotic over and over. And again, it was written for the same antibiotic from a walk-in clinic. So seeing that integrated view gave me lots of evidence, and to call the doctor and say, I'm not sure if you're aware of this. The The clinic next to me is paper-based, so they rely heavily on myself because they know that I'm using all of the tools. And of course, they're very, very collaborative. We have a very collaborative practice. And I said, they just had this antibiotic 4 times, I think it was, in the last 3 months. And so we had it changed. It was for a chronic ear infection. And I collaborated with the physician, had the medication changed for this small child. So that was just very, one small example of how the integrated view is so important. Initially, when I first started using it, it was for narcotics and controlled substances, and I used to present to pharmacists, and I had all this data from the first 2 weeks I had PIP in Saskatchewan. I had refused to fill 36 prescriptions for narcotic and controlled substances, and Doug Spitzig with the College of Physicians and Surgeons even commented, on how my one little pharmacy was impacting the use of benzodiazepines. And I just was like, I thought that was, a good reason for every pharmacist to use it, but my daily usage is for everyday ailments, asthma, Ventolin, seeing, asthmatics using 4 Ventolin a month, or small children on antibiotics from different walk-ins and different physicians, because the parent and their advocate isn't educated, isn't able to advocate for them because they don't have that knowledge at their fingertips. I hope that was...
So I know, Kimberly, I've heard you speak before, too, about how you also use the information from the lab system in your practice. So maybe you could just give us an example of that.
Sure. Yeah, I had that on my next page. So I was heavily involved with... I was on the steering committee for our lab result repository, which started 8 years ago. And I've had access to labs for 3 years now. And I was the first pharmacy to have access to labs, so I was involved in a lot of continuing education that is required for pharmacists to incorporate it, although I graduated over 20 years ago, just 20 years ago, and I was trained to use that data. So I finally felt, wow, I finally am using the knowledge that I had been trained with 2 decades ago. This isn't, it wasn't something new or, scary to me. It was just, wow, I could actually practice to my full capabilities by incorporating the lab data into my everyday practice. And also it has microbiology, pathology, immunizations on that on our Saskatchewan electronic health record viewer. So that's something I do for every patient. It's something you don't want to pick and choose who you want to access the data for, because the day that you don't is the day that you miss something. It's and that all my pharmacists, all my students, all my international pharmacist, IPG, international pharmacist graduate, I train them all how to use it and incorporate it into every patient encounter. And I'm a busy community pharmacy. I'm independent pharmacy, and it's a very busy practice. So, one example, this was a couple weekends ago when I worked, there was a 28-year-old girl coming in with an antibiotic, picture of health, and I filled the antibiotic and went to give it to her, and I just had this weird feeling. I'm like, I feel like I've missed something, and I'm like, it's just for Keflex. I'm just, everything's going to be fine with it. And I said to her, I'm just going to bring up your labs here. I do have access to it. And as soon as I brought up the labs, I'm like, oh, you have you have kidney disease? And she's like, yes, I do. And I said, have you had a recent renal panel? And she had a nephrologist who I also have a great collaborative relationship with. And she had on her phone a picture of her last data, of her last renal panel, which I made sure I looked at my renal panel on my lab data, and it was correct. So I calculated her creatinine clearance. Just because of her age, the eGFR I wasn't completely confident with, which is an estimated indication of how their kidneys are clearing drugs. So I calculated her creatinine clearance, and I was like, oh, this dose is just slightly high for you. I'm going to call your family doctor, and we'll see if we can get it lowered. And we got it lowered, and the family doctor is very receptive. And then I did want to mention as well that not only has it elevated patient care in my practice, I think that unfortunately the standardization of care needs to be looked at, because I feel badly that patients that come to my pharmacy are receiving this care when really they should be receiving it at any pharmacy in our province. The other really important thing is the increased level of collaboration with physicians that are aware that you are practicing to your full capabilities and are not working as a glorified assistant or technician, which I have said in front of a group of pharmacists. So I'm not sure if there's very many pharmacists here today, but if you're not using the data and you're kind of confident when this 28-year-old person looking fairly healthy is coming into your pharmacy, you're not giving them top-notch service. So the nephrologist that I'm speaking of invited me to his office, and we sat for a couple hours and chatted, and it has really increased my collaborative practice and the ability for my pharmacists and my practice to collaborate with other physicians, including specialists. He actually is CCing me for all of our mutual patients on all of his communication now. And this is just this is within the last 6 months that I've had a cardiologist and a nephrologist. I'm in their Towers Pharmacy is now in who they CC on all their communication, which is huge because we don't have access to their EMR systems yet, but hopefully that will be coming.
Okay, so I'm going to take us now to the next one. So we have a chronic disease management quality improvement program, and this is really a program whereby we try to manage, in conjunction with our physicians and other clinicians, that patients receive best practice care consistently for some of those chronic diseases. The ones we've chosen are ones that are really quite prevalent within Saskatchewan. So the intent of it is to improve continuity, improve quality of care. Physicians do receive an extra payment if they meet all of the requirements of the template on a regular basis. So it's not just doing the template, it's doing it on the right time schedule and all of those kinds of things. It is set up so that it is in each one of the EMRs that's approved within the province of Saskatchewan, and it is then extracted and sent directly to the electronic health record viewer, the EHR viewer. So you can either, if you're a physician on an EMR, you would actually fill out the template in your EMR, and then it would be extracted and sent to us. If you're not on an EMR, so if you're one of those few physicians who is still paper-based, you actually can fill it out directly in the EHR viewer. So there are 3 ways to get the information in. When you're then dealing with a chronic disease patient, you can see all of those interactions, not just the ones that were you. So it really is around supporting clinicians in providing best practice care to patients. And the templates were developed by clinicians. So nurse practitioners and physicians and other clinicians were the ones who actually pulled together this template, and then we worked with the Saskatchewan Medical Association to ensure it was implemented in. So currently we have diabetes and coronary artery disease that are already in. In January, we expect COPD, chronic obstructive pulmonary disease, and heart failure to be coming in. We're still debating what to do with the last 2 in Saskatchewan. Those would likely be asthma and depression, but they're having some difficulty clinically coming up with, at least on the depression, what is the key thing. So I'm going to now turn to Didi and ask him if you can tell us what kind of difference having the CDM QIP program has made to you and to your patients.
Thanks. This program has sort of revolutionized practice in family practice, especially in Saskatchewan, because we're able to pull information from patients that previously was unknown to us. So the problem, if you look at the context, when you're treating a patient with diabetes, you're trying to assess risk factors for coronary artery disease, other concurrent illnesses. If the patient's having encounters that are not recorded or are not sort of aggregated, you can imagine you only get a little bit of a snapshot of what that patient is experiencing. You're unable to tie in blood pressure readings from 3-4 months prior to what their current kidney state is, etc. What the CDM QIP flow sheets have allowed us to is at these scheduled visits, so we're essentially seeing the patient every 3 months, every 90 days. You get to pull all their blood pressure, for example, for diabetes, their most recent HbA1c readings, their most recent labs, and these are all automated. So they're integrated with our electronic medical record system, so you can pull that information in at once, document their weight, their blood pressure, etc. That information now can get uploaded into the EHR viewer, which is a province-wide viewer that all physicians and practitioners essentially have access to. So an example would be a patient that walked into the clinic with the typical request of, fill my prescriptions, and then you'd go, well, what was the last time you had blood work done? Now we can actually go back and see over the past year whether their blood sugar is actually controlled, whether their blood pressure medications need to be adjusted. Again, this is completely different from what it was about a year ago. So it's made a huge amount of difference in my own practice. On the patient side, it allows the patient actually an increased level of participation in their own care that previously was unavailable. So the patient's actually able to see in real time, sitting down there with you, well, what is my blood pressure doing? How can I take charge of all the little factors I need to adjust? What are the things I can do to make my blood sugar better? But we're also able to engage the patient now in their own care, which again, we know from all the studies and all the ancillary data that we really need to make this more patient-centered as opposed to more practitioner-centered.
So the third product that we're going to talk a little bit about that's all integrated together is the EHR viewer. So this is a secure website that presents healthcare providers with a wide range of patient information. So right now we have about 95% of all of the lab tests available. We do have all of the publicly administered immunizations, which in Saskatchewan is the vast majority. There are some that are provided by pharmacists and some that are provided by clinicians or physicians as well. But in that case, they'll often still put them into the public health system in one way or another. Although I was just hearing about an issue with that on the way in, so we'll try to deal with that. So it's the vast majority of immunizations in the province of Saskatchewan. As we've been talking about, the chronic disease management templates or flow sheets, that information is also in there. Medical imaging reports are there. All of the community dispensed pharmacy information is in there. And we also have a couple of things that we've just newly been working on, some synoptic reports, and we have some clinical documents, so discharge summaries as well. The other thing that's in there is the vast majority of hospital encounters. So if you go to the emergency room or if you are admitted or discharged, that information is also available in there. We're just, in the next month or so, hoping to put the last region on. So all of that information would be available to a physician or to a nurse practitioner or any other clinician who needed it. It really is intended, in our view, to complement the local clinical systems. So for physicians, we see EMRs as being the primary way that they would manage their workflow and work with their patients. In the hospital system, we use a hospital information system that would be the one that's used throughout the province. So that would, again, be what we would view as the primary system. But this is intended to complement and to make that information available. And we expect early in the next year that they will be able to launch the patient in context out of their working systems as well. So just on the final steps of that. So I'm going to first ask Barb if you can talk about your experience using the viewer and the difference it makes in patient care for you.
Absolutely. So my practice primarily deals with at-risk youth, and that's my full-time practice. And on weekends and evenings, I do some work for Southern Saskatchewan's child abuse team. So the patients that I see don't all live in Regina. Some of them do. Some of them are in and out of Regina. They're very transient. They're a very transient population. And so having the EHR viewer for my practice is invaluable. These adolescents will go wherever they can to get their health care, whether that's an emergency room and whether that's an appropriate emergency room visit or not, or a Medi Center. They don't have a primary care provider that they go to all the time. So their care is very disjointed wherever they go. So because I work primarily with adolescents, I do a lot of pregnancy testing and I do a lot of sexually transmitted disease testing and that sort of thing. And my motto has always been, it's never just a pregnancy test. And the EHR viewer really helps me with that because it never is just a pregnancy test. Even if that's all they want from me, it's about, okay, if it's not positive, what are we doing for birth control? What have you been on in the past? Well, I don't know, it was a pill. Well, that's great, but there's about 20 different birth control pills out there, and what didn't you like about it? And so we have all that opportunity, and I can look in and see what they were on, try something different, or give them the same thing if it worked well for them. Also, I don't know how many times it's happened to me where they say, no, I don't need STI testing, I've had it done. When did you have it done? Just last month, and I look it up. No, it was a year ago, hun. How about now? Or it was just last month, and whoever did it has still having trouble getting a hold of them, and they're positive for chlamydia, so I have them right there. So I never deal with an adolescent or my patients without logging into the eHealth viewer and see what's happening with them. As a nurse practitioner in the province of Saskatchewan, most nurse practitioners are focused on being accessible for people who don't have access to care. And so this summer we had a lot of forest fires in northern Saskatchewan. And so people were evacuated to many centers. In Regina, we had 1,600 to 2,000 evacuees living in between hotels and soccer facilities and rinks and you name it. And so the nurse practitioners were sent there to provide primary care services. So if you can imagine, you're evacuating your home, you take the medications you have with you, whether that's 5 days worth or 3 weeks worth, and you don't know when you're coming back to your home, if you're going to have a home to come back to. So when I went there to provide care, I felt like I was in a war zone, honestly. That probably sounds silly, but at the end of the day, I was like, oh my God, I can't believe how much work we have to do here for these poor people. But they would come to me and well, these are my meds, and I can't recognize them just by looking at them. I don't know what dose it is. I don't know which medication it is. So I was able to log in, see what meds they were on, see what dose they were on. They were able to verify that information for me. We were able to just renew those prescriptions. They had enough for the 3 weeks or month for some of them that they had to stay in Regina. We had a pregnant woman who we were able to see her ultrasound results. Her last ultrasound showed that they couldn't get a good view. I can't remember if it was the baby's heart or kidney, and they wanted it repeated. She was there. We were able to get that organized while she was in Regina. Had we not had access to that information, we would have never been able to do that for her. And so it's really been invaluable for my practice, and it's been invaluable for the people that I serve.
Didi, or I know I kind of made you go early, but is there anything else you'd like to add?
I think just the ability to see all of the information, to do med reviews, that's another task that pharmacists are reimbursed for in many of our provinces, including Saskatchewan. Just, if we didn't have access to the data, how would you do a med review with just drug information? And I'm not sure how pharmacists who aren't accessing the data, how they would perform a med review that would be satisfactory to the patient. I love our cumulative view because I can look at their A1C and hit cumulative view, and I can see it over the last 2 years, print it out to them, because they're curious too. They want the data, and I'm so glad to have Cecil here with us because patients want to see this data. I tell them, you own the data. Your doctor doesn't own it. I don't own it. You own it. And I have the ability to just point, click, here's a copy of the last 2-3 years of their A1C, and they embrace that, especially when we're doing the more in-depth med reviews. The examples I gave were like quick examples of patients coming into the pharmacy, but I use the viewer for those patients. I use the viewer when I do a med review. I have a long-term care contract. We don't have to drive to the home anymore to look at paper charts at the long-term care facility. We get the information quicker than they do at the long-term care facility. The physicians that I work beside that are still paper-based, we get all that data faster than they get it.
Didi?
My practice also is a little bit different in that I do quite a bit of telehealth, and I travel to smaller communities and Saskatchewan. Now, anyone who's been to Saskatchewan, which I assume is everybody here, in January especially, our geography is well suited to a diverse population that's geographically challenged in a sense. We have patients that have to travel great distances just to access sometimes the most basic ultrasound or to see a specialist, etc. So if you have a patient that's far away from a major center, they've had their blood work done in Saskatoon, they've had labs done in Prince Albert. The only way previously we could have seen all that information was to have each provider or each caregiver fax, dirty word, fax that information to one central place, which of course consumes an inordinate amount of time. Now with the EHR view, we're able to see these patients in different locations and access it in one cumulative view. And I think that's made a massive amount of difference. So just from the perspective of the future, I think making this more a central piece, and when we talk about interoperability, how are we able to transfer this information we have now for patients that travel to other provinces, patients that drive truck, for example, that traverse the country. I think that's really the vision that I hope that we're all aiming to, is to see how we can push these little things that work to a more national scale.
Okay. So the last thing that we're going to talk a bit about is something we call CHIP, which is Citizen Health Information Portal. And so we've been working on this, I guess, it's about 1.5 years. Yep. In that range. We kind of started by pulling together a group of patients and really significantly imposing upon them, but they rose to the challenge for us. We pulled 17 people together, provided some education on both what citizen or patient portals we're doing in other jurisdictions, what information we did have available in our centralized repositories to providers, and then asked them, what is it that you would like to see? And then we sent them out for 3 weeks, and we said, talk to anybody in your circles and talk to them about this issue, and what are the pros, what are the cons, what would add value. And then they came back and basically developed our core requirements from a citizen perspective. What was it that they really wanted and that would add value to them? Since then, we've kind of been working away at it. We expect that we will be able to launch a limited production run or kind of a pilot kind of process in January of this year, and we will have up to 1,000 patients that will be able to access some of their own data initially, and also be able to add information and share information with anyone they wish to. So it really is aimed to help citizens and patients take a more active role in their own care. Cecil has been with us since the beginning on that process, and so I'm just going to ask him to tell us a little bit about why he's looking forward to being one of the participants in that.
Well, as Susan mentioned, this started in the spring of 2014, where there were 17 people brought together, and we discussed a lot of options and went out into the community to bounce our ideas off of our peers. There was a lot of things that we brought back to the group after the time in the community, but there was 2 recurring themes that we discovered. The first was that people who had little or no contact with the healthcare system thought that it was working wonderfully. Surprise. However, those with serious illnesses or chronic illnesses thought that the system was broken. The second, and most importantly, what patients wanted was better access to their medical records, not only for themselves, but for their healthcare providers. See, there was a great deal of frustration with patients that the lack of accessibility to their health record meant that healthcare providers were asking them for their information, and the result being information that was incomplete or inaccurate. So what the panel came up with was a recommendation for what we called a front page. And we hoped that this front page would contain any and all pertinent information that was required for a patient's care. And this information should be available to the patient as well as the care providers. The feeling was that this portal should be available online so that it didn't matter whether you were at home in Regina or in Phoenix, Arizona, you could access the information through a cell phone, smartphone, iPad, or a computer. So at a recent meeting in October, was it the end of October?
I think so.
We were shown sort of a preliminary view of what this portal was going to be, and the expectation is that it'll be rolled out in January with 1,000 people having access. We're hoping that this will allow for more accurate information to be available to everybody, with the goal of eliminating some of the errors that I talked about before, and reducing or eliminating the time that's spent by healthcare providers trying to find out information from the patients, with the result being a safer, more efficient healthcare system for Saskatchewan people.